Hi, I'm Dr. Lauren Lam and I'm a Canadian dermatologist. Please note, this video is only meant for healthcare professionals. It's not meant for patients to self-administer, since improper technique or tools can lead to unwanted side effects, such as no improvement, indentation or lightening of the areas, or even infection. One of the simplest and most effective treatments for HS is an intralesional steroid injection. Any nurse or physician can administer this with the right technique. Flares can often occur in typical body folds, such as the axillae, the inguinal, inframammary, or gluteal folds, but can also occur in atypical or new areas, such as the back, the neck, preauricular areas, or the earlobes. Depending on how new the lesion is, intralesional steroids should improve pain and swelling symptoms within 24 hours. It should also shorten the duration of the flare itself. You will need suspended triamcinolone or similar liquid steroid, an 18-gauge needle for drawing up, a 31 or at least minimum 27-gauge needle for administration, a syringe, saline or lidocaine if dilution is required, gauze, and an alcohol swab. Draw up a maximum of 1 cc of 10 milligrams per cc of triamcinolone per lesion. Triamcinolone comes in two concentrations, 10 milligrams per cc and 40 milligrams per cc. If your bottle is a 40 milligram per cc bottle, dilute the concentration by drawing up 1 parts to 3 parts triamcinolone and saline in the same syringe. So for example, draw up 0.2 cc's of triamcinolone followed by 0.8 cc's of saline for 1 cc total of 10 milligrams per cc concentration. For 20 milligrams, just do 50-50. So 0.5 and 0.5 of each in the same syringe, and that will give you a 20 milligram per cc syringe dilution. Cleanse the lesion with alcohol. Then inject intradermally into the nodule. Inject as much as the lesion will allow for up to 1 cc per large lesion, but usually it'll be around 0.1 to 0.2 cc's. If possible, limit the number of injections to 1 or as few as possible to reduce the patient's overall pain. These lesions are highly tender, so the patient will really appreciate if you can limit the number of pokes. If you notice drainage coming out of the lesion after the injection, the correct depth was actually achieved, although sometimes they won't drain. Intralesional steroids should only be repeated up to a maximum of every 4 weeks. But if the same lesion is recurring more than once, then deroofing should be considered for that lesion to permanently eliminate it. One additional simple way to ensure systemic prevention and management of flares is to start the patient on doxycycline, 100 milligrams once a day for 3 months, along with the intralesional steroid injection if they're not already on a systemic therapy while they wait for a dermatology consultation. Other simple pain management tricks include diluting the intralesional steroid with an anesthetic, applying ice before the injection, or providing a prescription for topical numbing cream to apply before the injection or to flaring areas. Although simple, being able to provide this service to HS patients can't be underestimated. It can reduce unnecessary visits to the emergency or urgent care departments, misdiagnoses, unnecessary or ineffective treatments, and in some cases, even prevent unnecessary inductions during pregnancy. Thank you so much for taking the time to add this tool to your arsenal in treating HS patients.